Welcome, everyone. We've invited Deb Kaysen to come back and speak to us again. So we welcome her. Is this the second or a third time? So third time here, because she gives wonderful grand rounds. She holds the UW Medicine Depression Therapy Research Endowed Professorship and is also a clinical psychologist in the Psychiatry and Behavioral Sciences Department at the University of Washington. Dr. Kaysen is board certified in cognitive and behavioral psychology. Her research is situated at the interface of post-traumatic stress disorder and addictions, and includes both etiologic and prevention treatment-oriented studies. Dr. Kaysen conducts research across a variety of trauma-exposed populations, including active duty military, veterans, lesbians and bisexual women, torture survivors, and sexual assault survivors. She has been involved with several research studies both within and outside of the United States, adapting treatments for PTSD for low and medium resource settings. Dr. Kaysen.
Thank you all for coming today. I am amazed that people are willing to come for me doing another grand rounds, but I'm very pleased to be here. I'm going to be focusing very specifically on one part of that bio sketch, which is really talking about how do we address symptoms, predominantly PTSD and depression, in trauma-exposed populations, really looking at some of the research done in low and medium resource settings. And part of why I put this title up, it's a little provocative, but I think we all want a silver bullet. We all want an answer that will work for all people in all contexts. And we have some really interesting data that may inform that conversation. If you need me to do anything differently while I'm talking, by the way, to slow down, to elaborate, please do ask me. And if you have questions as we go, I might take a few, but this is fairly dense, so for the most part, I'll have you guys wait till the end. So in terms of an overview, these are the things we're going to be talking about. I'm going to present a little bit of an overview around the burden of mental illness internationally. I'm going to talk some about some of the challenges that face us in looking at mental health needs. And then I'm going to really focus in on trauma-related disorders and talk quite a bit about PTSD. And I'm going to be talking about 3 studies that we've recently completed, one in the Democratic Republic of Congo, one in northern Iraq, and one in southern Iraq. And then actually, we'll have a conversation about what are some of the lessons that we can take from this. So in terms of the global burden of disease, if you look at the years lived with disability, mental health concerns are among leading causes of chronic disability, and that's been true for the past 20 years. So according to the World Health Organization, mental illness and behavioral disorders account for about 26% of time lost to disability. Mental disorders account for more than 1/3 of the global burden of disease in terms of economic burden. And if you look at the direct and indirect effects of mental illness, currently it costs the world about $2.5 trillion per year. And the estimates are by 2030, it's going to increase to about $6 trillion per year. This is more than heart disease, and it's actually more than combined cancer, diabetes, and respiratory diseases. Now you would think that with that cost, we would really be getting out there and bringing treatment to the people who need it. But that's an epic fail. So this is actually the result of a really nice review of community-based psychiatric epidemiology studies. This is looking globally, and this is the gap between people who could benefit from treatment, so people who had the disorder versus the people who received the disorder. You can actually see that the place that we're doing the worst is around alcohol use disorders, which is another hat that I wear. But we're not doing great with GAD, panic disorder, and depression. There actually were so few studies that looked at PTSD, I can't tell you what the gap is in terms of global mental health, but I can't imagine we're doing a better job with that than we're doing with depression or other anxiety disorders. The estimate is that in high-income countries, about 1/4 of people with mental illness receive care, and in low-income settings, it's less than 1 in 10. Now, why is that? Well, there are a number of things that are getting in the way. First of all, there's a shortage of mental health professionals. So in low-income countries, there's about 0.05 psychiatrists. There's about 0.16 psychiatric nurses per 100,000 people. And the numbers are fairly comparable for our social workers and psychologists. That's compared to about 200 times more in high-income countries. And if you get outside of the cities, we're not doing great in the high-income countries either. There also is stigma associated with mental illness. And there's tremendous lack of funding for mental health. That may be a function in part of stigma. So at present, low-income countries allocate about 0.5%, and lower middle-income countries about 2% of their overall health budget to mental health care. The annual spending is less than $2 per person, and in low-income countries, it's less than 25 cents per person. I think part of the reason for this is there may be a perception that we actually don't know how to treat these disorders, or that they are actually somehow untreatable. I'm going to be actually talking some about these 2 points. So the research studies that I'll be touching on a little bit look at some possible solutions for that shortage, as well as maybe addressing this idea that we don't know what we're doing and we really have no answers. I hope that's not the answer, because then we really have no silver bullets. And I better find a different job. All right, so one piece that's really been understudied, if you look at the global mental health field, is the effects of trauma exposure and treatment for related mental health symptoms. Okay, now, part of why I care about this is that exposure to traumatic stressors and the mental health disorders that can go along with that are actually quite common. So if you look at a survey that was done from the World Health Organization, where they looked at 21 different countries, you find that around a quarter of people have been exposed to traumatic stressors. And within conflict-affected populations, about 15% of people meet criteria for PTSD, and 17% meet criteria for depression. And unfortunately, for people who don't receive treatment, PTSD becomes chronic. So about 40% of people who actually develop PTSD recover within the first year after trauma exposure. So some people get better without ever talking to somebody like me or somebody like the great people at HCSATS. About a third to a half of those with PTSD don't recover though, and it becomes a chronic mental illness. And one piece that does make a difference is actually access to treatment. So if you look just across all treatments, not just what we think of as evidence-based treatments, you could actually lop off almost in half the number of months that somebody will suffer from PTSD. Now, part of why I care about that is because PTSD is an expensive disorder. It's expensive in terms of personal costs, and it's expensive in terms of societal costs. So this is research that was conducted within the United States. What they found is that for people with PTSD, they had about 150% higher chance of being currently unemployed. They had a much higher chance of marital instability, teenage childbearing, and dropping out of school. People with PTSD miss about 3.5 days per month. That's actually fairly comparable with major depression. In 2000, it was estimated that we lose about $3 billion per year due to lost productivity. And more recent research looking at just veterans coming back from Iraq and Afghanistan, that it's costing the U.S. about $923 million per year. Now, on the flip side, we actually have treatments that work, and they're really pretty short. So this was a study that was conducted, the original study in 2002, and then we did a long-term follow-up in 2012. And this is looking at 2 different evidence-based treatments for PTSD, cognitive processing therapy, which is actually mostly what I'm going to be talking about today, but also prolonged exposure. And you can see that after going through about 9 to 12 sessions, only about 20% of people still had a PTSD diagnosis at the end of treatment. That's why I do these treatments, right? Because it's fun. You get to see people get better. Okay? And when we followed people up 5 to 10 years later, we still see about 20% of people meet criteria for PTSD. Once we get the symptoms down, they don't tend to come back, which is pretty powerful. The results are really similar for major depression. All right? So when we looked at current depression comorbidity, about 50% of the women in that trial also met criteria for current depression, and about 10% of them met criteria for major depression 5 to 10 years after they finished treatment. Okay, and these were all people with chronic PTSD. Now, in general, there are guidelines that have been developed by the World Health Organization on how to address mental health problems after exposure to extreme stressors. So there are sort of two categories of disorders that you can see once somebody is exposed to traumatic stressors. There are disorders that occur in other contexts, so depression, substance use, anxiety disorders more broadly. If you're exposed to trauma, you have a higher chance of developing those disorders. And we actually have recommendations from the World Health Organization about how to treat those disorders in low and medium resource settings. But there also are problems and disorders that require exposure to stressors, like PTSD, acute stress disorder, traumatic grief. And the World Health Organization hasn't had as much research to guide them in making recommendations about what to do about this in low and medium resource settings. On the flip side, we actually have a number of published guidelines on what to do with disorders related to traumatic stress that have been around for a while. So there are several different guidelines that exist, but they make some pretty limiting suppositions. One is they're not at all designed for non-specialized healthcare settings. So they assume that you have a me in your setting to deliver that care. They are not designed with an eye towards some of the challenges in low and medium income settings, and they're really focused predominantly on PTSD. So some of the questions we're going to be talking about today are, can you use some of the evidence-based treatments for PTSD in these types of settings? So outside of University of Washington outpatient psychiatry clinic. And will these treatments improve functioning for people? Can these treatments be implemented by folks who don't have specialized mental health training? And how much do those treatment outcomes vary from place to place? So I'm going to talk first about a study that was published now a couple of years ago on some research we conducted in the Democratic Republic of Congo. The first thing I want to say as we move into the research studies is on these studies, it's kind of funny to talk about them because I'm basically the voice talent. So I'm the CPT and clinical expert in these studies. I didn't actually come up with the research design. So I'm not going to talk very much about the overall research design. I'm going to touch on findings, but my job is the clinical expert, and that's really more of what I'm going to focus on. So in Congo, there are very high rates of violence against women. DRC has been named the rape capital of the world. Estimates are that at least 40% of Congolese women have experienced sexual violence. And there are estimates that about 1,000 women and girls are raped in eastern Congo every month. And at the same time, there is very little mental health infrastructure. So it's estimated that in DRC there's about 0.04 psychiatrists and about 0.01 psychologists per 100,000 people. The local counselors, because there are local counselors, have very little mental health training. And most of the mental health counselors have maybe a middle school to high school education. There are very few mental health beds. There are 3 psychiatric or hospitals that have actually psychiatric services in them, and very little access to psychotropics, and a very wide geographic range. Just to give you a sense of perspective, DRC is about the size of Western Europe. Yeah. And now, we have this therapy, cognitive processing therapy. It's considered to be an evidence-based psychotherapy for PTSD and comorbid depression. And there have been about 9 randomized clinical trials that have been conducted in the US, and now 1 has been completed in Australia. It's a 12-session therapy. It can be conducted in either groups or individual settings. And it predominantly works on changing trauma-related beliefs And it can include a written trauma narrative where the person writes down what happened to them, but it doesn't always include that. It's typically implemented by people with a master's degree, a PhD, or an MD. If you look at the VA, there actually are guidelines around that you need to have those types of degrees to deliver this therapy. And the way we typically train people up is we do a 2-day training. Jordan and I are going to be doing that in a couple weeks, right? And then we give you about 6 months of phone case consultation. Now for this study, just to give you a sense of the overarching design, we looked at an economic intervention, a supportive therapy, and cognitive processing therapy for Congolese survivors of sexual violence. The study included adult women, and all of them reported a history of sexual assault. And they presented with elevated depression or PTSD symptoms, so you could be included for either set of symptoms. Now, the way we think CPT works, at least this is the theory, is that we do basically 3 things. The first is that we actually reduce avoidance of trauma-related reminders. So we've got to stop people from avoiding things that are actually safe, but that they're not doing because it brings up emotions or thoughts about the event. We help them process the emotions about the traumatic event, and then the therapist and client together work to help the person develop more flexible, balanced beliefs, both about the trauma itself and why it happened, and about the implications of the trauma, what it means for their beliefs about the world, themselves, and other people. So you're really teaching the skill of metacognition to help get beliefs that are more balanced and accurate. It is not positive psychology. It is not necessarily coming up with happy thoughts. It's coming up with accurate thoughts. So, but if you look at the therapy in the US, it's very writing intensive. And when we did, I recently made the people at the VA actually look at the treatment materials and run readability statistics on it. And most of them were written, despite what they said, at about an 11th grade education. So we've made some changes to that as a result of this, but it assumes a fairly high level of literacy. So we had to make some changes to CPT to work in Congo, where the women in the study had on average between 1 to 2 years of education. And there is no culture or history of talk therapy. So the first thing we needed to do was actually add some information in about why you might talk to somebody about these kinds of problems, okay, and what that's likely to look like. We also needed to really shift how we do homework in this therapy. So one of the ideas with the therapy is you have to do practice to learn skills to get better. But if somebody can't read or write, we needed to make this something that could be memorized and integrated into the person's life. And we used a lot of pictures, and we used some physical exercises to help with memorization. So if you do CPT here, this is what we give clients. This is one of the skills. It's sort of the bringing everything together skill. This typically, when I'm teaching new therapists, engenders some anxiety for the therapists. This is what it turned into in terms of teaching the therapist the steps in Congo, which is you do 5 things. What's the thought? What's the feeling? We ask them to ask 5 questions to test the thought. What's a new thought that's more balanced or flexible? And how did that change your feelings? 5 steps. Now the other piece is, and I bring this up because since this study has been published, I've gotten a lot of requests to do this, what I call train and go. Can you do a training here? Can you do a training here? I am adamantly opposed to that model. I actually think it's hurtful. Okay. What we did for this project, and I think is essential, is train and support. So there was a whole system in place during the entire trial to support the therapists and the supervisors in how to do the therapy properly and effectively. So what this meant was myself and a social worker from Harborview did the training, and we did weekly phone calls with our supervisor. The supervisor was a US-based social worker who lived in Congo for about 8 months while the trial was going on. And she met weekly with the field supervisors, and every other week she would go and visit a site to observe how the therapy was being delivered. We then trained Congolese nurses as our field supervisors. We asked them to co-lead a group, so they got some of the hands-on feel for the therapy, and they met weekly with our therapists. And they also went out weekly and observed therapy in at least one site, so they could give immediate feedback on how the therapist was doing delivering intervention. And then the therapists were community health workers. They're called psychosocial assistants there. We had one person who graduated from university. Everyone else had about a high school to middle school education. And they led 1 to 3 CPT groups weekly. And you'll notice that these arrows go both ways. So there's ongoing monitoring and feedback through the whole system about what's working and what's not working, where we can help support therapists, but we also get some feedback about things in the therapy that might need to shift for this context. So here's how we did. So treatment as usual in this trial was an active treatment. It was supportive therapy, active listening, referral services, mediation, and it was part of the package that the NGOs had already been delivering. And you'll notice that it was effective. This was not ineffective. However, the odds of remission for PTSD and depression were about 15 times higher for the people who received cognitive processing therapy. If we look at PTSD symptoms specifically and look at symptom severity, both the treatment as usual condition, or the individual support, and CPT led to significant improvements over time. But again, we saw in terms of severity and maintained at 6-month follow-up, significantly larger improvements for CPT participants. Very similar pattern for depression, and similar pattern for functioning. So functioning was how well women could live their day-to-day lives. How well can you work in the fields? How well can you cook for your kids? It was a 20-item scale about daily tasks and activities for women in Congo. So for the women who got CPT, about a 50% higher improvement in daily functioning versus 23% for treatment as usual. So the conclusion for that for us is that if you supervise group cognitive processing therapy, it can be a really helpful addition for that individual support for improving depression, PTSD, and improving functioning. And that paraprofessionals can deliver the therapy well as long as you have effective measures in place to give them some support while they're learning. And that interventions can work in conflict or crisis settings. So while this trial was going on, we had therapists and clients who were actually sleeping out in the forest at night because it wasn't safe to be in their homes because rebel forces were kind of moving in and out of the villages. And we had a group member who was killed while the trial was going on. So the fact that we got effects still somewhat astounds me. So now let's shift gears and talk about 2 studies that were done in Iraq. So the first study is actually now in press, and then the second study is under review. So this work was conducted in 2009 through 2012. And the reason why I highlight those years is the situation in Iraq now is very different than it was when we were doing these trials. Just some context, in the 1980s there was pretty systematic genocide of ethnic Kurds in northern Iraq. In 2003 there was war and sectarian violence. But in 2009, northern Iraq was actually relatively stable. So there had been widespread trauma, but the region overall was fairly stable when we went in to do the trial. In contrast, when we did the trial in southern Iraq, there was still ongoing violence and instability. And in fact, we never went to southern Iraq. All of our trainings were held in northern Iraq. There are high rates of exposure to torture and to trauma, and there were ongoing problems with poverty, discrimination, stigma, mental health problems, and quite a lot of problems with economic and physical functioning. So for the Northern Iraq trial, the trial itself looked at a depression therapy, behavioral activation, versus cognitive processing therapy as compared to a waitlist for survivors of torture. Now this study included both men and women. People had to report a history of torture, but torture could include having someone you know be tortured. or witnessing torture, not necessarily directly being exposed to it. And people needed to present with elevated depression symptoms at baseline. So slightly different inclusion criteria than what we found for what we used in DRC. We used the same type of tiered model for supervision and monitoring. We had 2 psychologists who did about a 1 to 2 hour Skype call. Our field supervisor was an Iraqi cardiologist because we could not actually get anyone in northern Iraq who had a mental health background, who also spoke English so we could communicate with them directly. He needed to finish 2 CPT cases. He actually wound up as a dynamite CPT therapist. And he did weekly supervision with the community mental health workers. And then he went out every other week to visit them in the fields or visit them in their settings. The therapy was delivered at community health settings, so kind of an integrated care model. And our therapists were doing CPT, but they were also drawing blood and delivering babies, which created some drama during the trial. Why did you miss a session? I was up all night delivering a baby. All right. And then the therapists saw their participants weekly in theory. And we'll come back to that later. Now, in southern Iraq, what we looked at was a components-based intervention, cognitive processing therapy again, and waitlist. And this was also for survivors of torture. It also included adult men and women. People needed to experience or witness torture or militant attacks. And the CPT part of this trial was in the Basra, and I can't pronounce that region. And they presented with elevated PTSD symptoms at baseline. So again, slightly different inclusion criteria. And slightly different supervision structure. So we had the same 2 psychologists who worked in northern Iraq. We had a supervisor who was our Iraqi cardiologist from northern Iraq, but he was still in northern Iraq, so he couldn't observe anything going on in southern Iraq because it wasn't safe for him to go there. And then he moved to Scotland partway through the trial. One thing I've learned from this is doing this kind of work, you got to roll with all kinds of things you wouldn't have predicted. And then we had a psychologist. Oh my gosh, a psychologist. However, he was an experimental psychologist who really actually had no clinical training. And we had some interesting experiences with that and the fact that he didn't have training in clinical ethics or procedures. And then we had a psychiatrist who was fabulous. And we asked them to complete 2 CPT cases as well. And then they were supposed to do weekly group or individual supervision with their therapists. And they did very rare field visits. So we got very occasional field visits from them. And then the therapists were supposed to see patients weekly. Okay, so let's see how it turned out. Okay, so this is CPT in the north versus the waitlist controls, and CPT in the south versus waitlist controls. For PTSD, we got significant improvements both in pre and post, and CPT over controls. The effect sizes are more modest than what we saw in Congo, but still significant. Yeah?
Did you say the experience from versus?
Not yet. Yeah. We're getting, I think there are a lot more questions than answers. And that's one I would be really curious about. Depression. CPT in the north, we did not get significant improvements on depression, which makes this trial unique in the entire CPT literature. It is the only one where we have not gotten significant improvement on depression, as well as PTSD. I think there's a reason why, but it is really curious. Okay. But we did in southern Iraq. Again, more modest effect sizes. Functioning. We got significant improvements in northern Iraq for improvements in functioning, but really nothing in southern Iraq. Okay, so now we get to some of the interesting, yeah, John, you got a question? Yeah, so we're using basically the same, so northern Iraq, southern Iraq, and Congo are using basically the same or similar scales. Yes, you're exactly right. So all of the symptoms were higher in Congo, level of trauma exposure was higher, and they were more impaired in terms of function. Good eyes, John. I know, but we don't get to randomize people to bad things, right? I said we don't get to randomize people to bad things, so we kind of get what we get with this kind of research. But it means there's more noise in the system. So, I was talking to Paul Bolton, who has been sort of the overarching PI across these studies, and what he said to me is, this is really interesting, because we've got the same intervention, we've got basically the same trainers, we've got basically the same training structure, the same supervision model, and we're all using paraprofessionals. So this is kind of a puzzle, because we've got a slightly different pattern of results. Why is that? So let's look at some of the things that were similar or different across these studies. So, and in some ways, this is kind of the data of the talk. This is the interesting part to me, is let's look at these a little bit more in detail. So, it may be that differences in the type of CPT helped influence these outcomes. Right? So 2 of these studies used individual therapy, and 1 used group. So maybe it's that group is more powerful. Maybe we got a lot of bang out of our buck for doing group. Okay. So that is possible, and I will tell you that the group format was incredibly powerful in Congo, and it was selected due to cultural appropriateness for that context. So that was a strategic decision for us. If you look, though, in the U.S. and look at the effect sizes for CPT as an individual therapy versus group in studies in the U.S., group doesn't do as well. It works, it's still really effective and powerful, but it tends to have slightly smaller effect sizes. So I don't know that this is all about group. I wish that would be easier fix. Maybe it's the type of CPT. So Northern Iraq and Southern Iraq included that trauma narrative. DRC, we left that part out, in part because it's very difficult to use when you do CPT in a group format. That one may have made a difference. So there is one trial that was a dismantling study where we took the trauma narrative out. And what we found is the therapy worked faster and had a lower dropout rate. So that may actually have made a difference. Okay? But in that trial, everybody got to the same place by the end of the therapy. There were no differences at the end of treatment. It may be the structure of CPT. So Northern Iraq had all of the parts of the individual CPT. We changed the language, we simplified some of it, but it has all of the parts. Based on feedback from our therapists, in Southern Iraq, we actually deleted one of the skills, which is a relatively abstract skill looking at overarching cognitive patterns. And we also added in one session to work on therapy buy-in. So that may have made a difference. And we kept that format for CPT and DRC. We also had different accommodations for literacy. Because we were working with mixed literacy populations in Northern and Southern Iraq, and we were doing the therapy individually, we kind of had the therapist do what worked for the individual client. And we guided them around that in supervision. In DRC, we knew folks couldn't read or write, and we were doing group therapy. So we just said, there's no reading, there is no writing in this therapy. We are getting rid of everything. We are just having people memorize. And maybe that had a helpful impact in people integrating the skills into their day-to-day lives. There also were differences in these trials across who got the therapy. So gender. Northern and Southern Iraq were men and women. DRC was women only. We did look at gender in the Northern Iraq study. And we found that women responded better across all outcomes, for depression, PTSD, and traumatic grief. So gender may have had an impact. It also may be confounded with type of trauma. So even in Northern and Southern Iraq, although people were torture victims, people could pick whatever type of traumatic event they wanted to work on as the trauma or as the index trauma. So, women had much higher rates of sexual victimization in general. So it may be that CPT works especially well for certain types of traumatic events, but may not work as well for some of the others. The inclusion criteria were different. So, Northern Iraq was high depression, and people might not have been directly trauma exposed. So we may have mixed in with this group a true depression only, not trauma-related depression group, and then provided a trauma therapy for them. This is clinical relevance because this comes up for me in supervision all the time. I have trainees who say, I got this person, and they were sexually abused as a kid, and they're depressed. Can I do CPT with them? Based on this, I would probably say, we have some really great therapies for depression. Let's start there. Okay. Southern Iraq people had high PTSD. And DRC, they had both. Or they could have either, is actually a better way of saying it. Now, there are also differences in adherence, monitoring, implementation across these trials. And I think this is really important to think about. Northern Iraq, we had intermittent session attendance, and that was true in Southern Iraq as well. We had clients go missing. We had therapists go missing. In Southern Iraq, we had supervisors go missing, sometimes for 6 to 8 weeks at a time. Okay. This therapy may be sensitive. In fact, I would say it probably is sensitive to people who are not coming in for whatever reason. And I think you lose a lot of momentum when that happens. This has implications for all of us who are clinicians who are trying to do this therapy. DRC, in part because it was a group and there was accountability, and we implemented the therapy on market day when people were already in town. We had amazing session attendance, probably the best session attendance I've ever seen in a trial anywhere. Okay. Dropout rate was actually pretty comparable across the trials. Practice completion. We know based on the therapist's report that doing that practice was pretty variable in Northern and Southern Iraq. DRC, the therapists tell us that the clients actually did the practice extremely reliably, but at the flip side, they didn't write anything down, so we have no way to check. Okay. And then supervision. So, Northern Iraq, Dr. Garan attended some of the sessions. He was actually able to observe how the therapists were doing the therapy. Southern Iraq, we really had very little direct knowledge of what was happening in the room. We had problems with insecurity where the supervisors couldn't get to sites for extended periods of time, and our supervisors did not speak English, so we could not communicate directly with the supervisors. DRC, supervisors attended sessions, they gave us feedback. They didn't speak English, but we had a US-based social worker who was there to be our eyes and ears in the field. There also were differences in the training and supervision of supervisors. So, the supervisors, Northern Iraq, we had a physician. Okay, he had never done psychotherapy at all, but he was really excited and open to learn about it, and he completed cases. Southern Iraq, this is actually the place where we had the most mental health expertise, actually, of any of the trials. But one thing that did create some challenges were that the therapists had some set theoretical orientations, as did our supervisors. And so sometimes when you walk into a room with preconceived notions, I'm fighting upstream in a training to think about getting you to do something a little different. Okay? DRC, nobody had prior mental health training, basically. We had nurses. Now, one thing that I do think is interesting, I have always said that I want my supervisors to complete CPT cases. I don't think you can teach what you haven't done. But we actually couldn't get them to complete a total group because of the logistics pieces of them getting to the sites to deliver CPT. So our supervisors actually had the least hands-on experience in Congo. Now, Northern Iraq, we trained our supervisor while the trial was ongoing. So we had trained an original supervisor originally, and then he left before the trial started. And so Dr. Gran came, and he came to a CPT workshop here in Seattle, and then we had to train him and had to supervise this once he got back to Iraq. And so we modeled supervision skills via Skype. Southern Iraq, we trained the supervisors in how to do supervision a little bit during the training. In Congo, we actually trained the supervisors in how to do CPT supervision during the training. So we had a little auxiliary training in how do you do this. Had them give feedback to therapists and then gave them feedback on whether that feedback was on target or off. So we were really building up some of the support infrastructure as the trial was going on. And then the training itself was different. Right? So Northern Iraq, Kristen and I were figuring this out as we were going. It was very didactic heavy. Looking back on it, I cringe a little bit. We modeled skills and we did some role play, but not that much. Southern Iraq was still a little didactic heavy, but we started to integrate therapist role play with feedback. DRC, much less didactic, and we had role plays go, and we would teach the skill, show the skill, have them do the skill, and then get feedback on what they did right and where they made mistakes, so they got immediate feedback. This has implications for how we do trainings here. And we became more experienced with doing this kind of training. I had to let go of some sacred cows I had of what couldn't change in the training and what couldn't change in the model. So I would come back to this and say, was it the same intervention across these trials? Parts were. Was it the same trainers? And we changed as a result of what we learned. Was it really the same training structure? And was it the same supervision model? So, some take-home thoughts. Trauma-related disorders are common. They have huge human costs. And we actually have a handle on how to treat them. But we're not bridging the gap to care. We have trauma-focused therapies that actually do a good job in a lot of places and improve functioning. But there probably is not one perfect answer for all people in all places and all times. And so thinking about where did CPT work really well, what were some of these differences between trials may help us pick the right intervention for a place. I would say that overall these studies do support the use of paraprofessionals. You don't need to have a PhD to do this therapy. Thank goodness. And we still have a lot of challenges ahead of us. First of all, we need models of interventions and how to train these interventions that are scalable. I'm not sure that the models that we've used for this in terms of training and supervision will scale yet. We also need interventions that people are less likely to break. Because in some places, coming in weekly is not going to be feasible. And I think the biggest piece is this has got to become a priority for governments, for funders, for the Gates Foundation. People have got to start helping us address this treatment gap. And my last piece are some thank yous. So Judy Bass and Paul Bolton were the study PIs. I had brilliant and fabulous co-trainers for doing this work. So Kristen Lindgren, who is my trainer, my co-supervisor, my co-treatment adapter, and my auxiliary brain. And Kristen and I spent many hours at 2 in the morning trying to figure this stuff out. Shelley Griffin, who was my co-trainer in DRC. Laura Murray, who was the mentor in how to do treatment adaptation for me. USAID funded this work, and we had amazing NGOs, clinical supervisors. Our translator, Amani, in DRC is brilliant, and our treatment teams. What questions do you guys have? Yeah, Jordan. You want my best guess? Because I don't have an answer, I just have guesses. I think that we had a lot of just depression, that it was not trauma related, that we had people where they had a trauma and they had depression, but those things were not causally related, right? Now, in theory, CPT should work for that because it is based off of a really good cognitive therapy for depression, but it still has a really strong trauma focus. Does that make sense?
Yeah, and you mentioned that women do better.
Yep. They did. We got significant results on depression in women, for women. Yeah, there's lots of cool questions to ask. Oh, and I'm supposed to also go to the thing. Do you want to get at the to see if there's also questions outside? I'm not going to flip. I don't do PCs. I'm a Mac girl and PC girl. All right, what other questions? Yeah.
Sounds like there are three different cultures. One very, very different from Congo, and then two that have CCA. The differences, how much is the cultural context?
I think culture actually played a big role. And I actually would say Northern Iraq and Southern Iraq are very different culturally. So the ethnic Kurds and the Arabs in Southern Iraq, there were quite a lot of differences as well. The place where I saw it play out the most was actually in Southern Iraq. So CPT, the meat of CPT is asking really good questions. And the group in Southern Iraq had a lot of trouble with asking rather than telling. There was a real pull to, let me just tell you the answer. Now, that happens any place you train CPT, but it was a little more rigid and hard to address there. So, and we culturally adapt the therapy in all of the contexts. I didn't talk as much about some of the ways that we did that for this particular talk, but we have done that through all of these trials as well to try to make it responsive to the local context. Other questions? Yeah. It's so mental illness is highly stigmatized in all of these regions. I think there was more awareness of mental illness in some of these contexts. In Congo, there really wasn't even a cultural footprint for thinking about it as much. Northern Iraq actually had some mental health infrastructure, so there were a number of psychiatric beds. We actually could facilitate psychiatric hospitalizations, which made me super happy because we had somebody become psychotic during the trial. The treatments they were using were not necessarily what we might think of as evidence-based interventions. We did get a number of cases of people, especially women, being hospitalized and receiving ECT for sort of bad household circumstances. But there was more infrastructure and knowledge about mental health in Northern and Southern Iraq. The place that I think that stigma played a big role there was it was harder to get people into that trial. The research staff in Iraq had to do a lot of legwork for us to get enough people to come in. And I think a lot of that was about stigma. So part of what the therapists talk about is they actually use some nice, almost like MI skills to pull from the person, what kinds of problems have you been seeing as a result of this? They do some discussion of some of the models we think about for how avoidance, right? It's understandable why you would push that stuff away, but we actually find that approaching it can make it better. We talk about the idea of practice. So in Congo, we use an analogy of had to learn how to sew, because the women have the most beautiful hand-sewn dresses I've ever seen in my life. How'd you learn how to do that, right? What did the first dress look like that you made? And usually we would get sort of the local equivalent of a hot mess, right? Okay, so this is going to be similar, that we need to have you practice. What I thought was interesting in terms of expectations, in both Northern and Southern Iraq, there was an idea of, I can take a medicine for this. Give me a medicine to fix this. In Congo, what people wanted was economic assistance. So I feel badly. If you just pay me money, I'll feel better. And I mean, in all reality, the women's economic circumstances are hideous. It's horrible. I can absolutely understand that. But there wasn't, it was more of, if you give me money, I won't be depressed anymore. Other questions? Yeah. Absolutely. I actually, so Dr. Lindgren made me take that slide out. We did. So there actually, we did post-intervention interviews for all of the trials, and we've analyzed the results from Congo, because that research project is just a little further along, and got really interesting feedback from the participants about what it was like or what they felt like they gained from doing the therapy. Some of the themes that came out of that, a sense of strength, increased harmony, more social connectedness, decreases in shame, feeling like the assault wasn't their fault anymore. And since that was one that we really specifically target in CPT, I was glad to hear that that came through in some of the qualitative analyses. Other questions? What about the people from far away? BB 1640. So do you guys have answers for me? What have I not thought about? Seriously, I've got this like group of minds all smarter than me. What's the magic answer? Why are we seeing differences? Yeah.
Why is simple
I have no idea. In some ways because that's above my pay grade on the project, right? Because I'm a clinical person, I'm not having to analyze that. My understanding is that they have analyzed some of the information about the declines and accepts, and there were not striking differences between the people who elected to participate or not. We've looked at dropout. The major reason why we found that people dropped out was actually because they moved. And the dropout rates are pretty low as well, actually lower than we see in the US trials. So, yeah. Absolutely. Yeah, absolutely. And so keep in mind, these are the people who also have not gotten better based on what is available in their communities so far, right? So that's not to say that there aren't local things that actually work really well, and I think we have a lot to learn from what communities are already providing, and these are the people who are still symptomatic many years after trauma exposure. So I think it's important to look at both, and having a range of options is probably the best solution. So remember, the place we started is probably no silver bullets, right? I would not ever say that you should provide CPT for every person who's trauma exposed, ever. I'm not even going to say that for people with PTSD who are trauma exposed. I think it is really about having a range of options if we're actually going to do a good job as a planet in helping people recover from trauma exposure. And I think we have as much to learn from the folks in Congo and the folks in Iraq about what they've tried and how that's worked out as they have to learn from us. It's got to be a two-way street. Yeah.
One of the things across the board is, especially in Congo, is the
Correct.
okay, the trauma is over and all that stuff.
Yeah.
These people who walk out the door and still be exposed to it.
That's right. Yeah, so for those of us folks who work at Harborview, that's probably good news, right? That you can treat PTSD in folks where there is ongoing violence and instability, right? To me, that's actually one of the optimistic pieces. And it was a surprise, and it was one of the things that we explicitly looked at in the data from Congo. Yeah. So we did not train community leaders in how to do these interventions. There's lots of neat work. I'm mostly aware of the work going on in Congo in involving community leaders in things like violence prevention, working on the role of women, sort of awareness training and trying to decrease rates of sexual assault. I don't know that community leaders would necessarily be the people that you would or wouldn't want to deliver the intervention, right? I think it would probably depend on the community leader. We also, in all of these trials, fired therapists. So not everybody can actually learn how to do this therapy and be good at it. Every single trial, we fired therapists for not actually being able to do the therapy in a way that we felt was safe and effective. So I think it would depend on the community leader. Yeah, why don't we do this as the last one? Cool. Such a great question. I think wherever we can, right? So I think this is a great question around pros and cons, right? So in DRC, this was implemented in the equivalent of specialty mental health care. It was implemented in what are called listening houses, which is where sexual violence survivors go for medical care predominantly, okay? But they also receive supportive counseling. Okay? Iraq, it was at community health centers. We have just completed a small implementation trial in Congo, training mostly dietitians in doing CPT in the equivalent of primary care. And the results actually look pretty similar to the large RCT. So I haven't seen final numbers, but looking at the session-by-session ratings, it actually looks pretty similar with slightly higher rates of dropout. I think the downside in a community health setting is it's not like in DRC, the physical health stuff is going well and just mental health is being neglected, right? And so if you're going to pick up something new, you have to put something else down, right? Or you need to add more resources in. And so I do think that if there's an expectation that people who are providers in community health settings who are trying to do vaccinations, deliver babies, deal with dysentery, are going to also do CPT groups, and you're not going to add any extra staffing, what are they not going to be doing? Right? On the other hand, it's where a lot of people go to deliver babies and do all of the other life things that they need to do. I think it's where will people come? So that's actually kind of a nice note to end on. Thank you.